Welcome everyone to our Survive and Thrive webinar series. I am Rachel Perkins, the Education and Outreach Specialist for Texas Oncology Foundation. If you are a cancer patient, a caregiver, or professional and want to educate yourself about the cancer world, we invite you to subscribe and join us every second and fourth Tuesday of the month. We are glad to have you all here with us today, and we are excited to hear from Francesca Caponi, a licensed clinical social worker, with a presentation on Passion Prevails, Rekindling Intimacy in the Face of Cancer, which is just in time for Valentine's Day. So I'm going to give a little bit of a background about the foundation. The Texas Oncology Foundation is dedicated to providing support to cancer patients in the communities where they live, work, and receive treatment. And through Survive and Thrive programming, the foundation can provide educational events like this one and resources to help build community connections and support all affected by cancer. All right, so I'm going to go ahead and introduce Francesca Caponi. She is a licensed clinical social worker who has worked in the social work profession for over 7 years. Francesca holds specialized experience in the medical field, providing integrated behavioral health and psychosocial support for clinics and hospitals. Therapeutically, Francesca supports a range of mental health diagnoses associated with cancer, including depression, anxiety, intimacy, adjustment, and guilt, as well as help in navigating the complex resource needs patients might encounter in their treatment journey. So Francesca, if you want to go ahead and go off mute and share your screen with us today, we are so excited to have you.
All right. And there we go. Are we good, Rachel?
Looks good.
Awesome. Great. So excited to be with you guys. I wish that I could see your faces. It's so weird not being able to see any of the participants, but I'm glad that you're all here with me. Welcome, welcome. So today we're going to be exploring the impact of cancer on sexual health. A lot of learning, a little bit of a cancer sex ed in the beginning. We're going to be learning how our physical structures are impacted, exploring the emotional toll of cancer, because that's a big one, and it does actually affect our sex life, and then the ways that we can start to reintegrate this part of our being back into our daily life. We will be, just as a heads up, going to be exploring biologically female and biologically male structures during this presentation. This may or may not correspond with your gender identity, but most of us, regardless of identity, are going to have parts organized similarly to those shown today. I also want to cultivate a brave space as much as we can, and we're all going to be coming from different places. Whether your sex life right now is a place that feels safe and fun, or it's full of frustration and ambivalence, we are here for all of that. Okay. If you're feeling uncomfortable or overwhelmed at any point, please take the space and time that you need, and I'll be available after the presentation for a short amount of time to answer questions that might pop up. Again, put them in the chat as we go along. Let's get started. I also want to get my handy dandy pointer here. I like to use it. Okay. There we go. All right. Let's dive in. So as many of us know, the reason we're here, sex is a vital part of health. The effect of cancer on relationships and physical intimacy is pretty profound, right? There's no doubt that the physical and emotional impact of cancer and its treatment influence our relationships, both with ourselves and our intimate partner. And a person's sexual desire and function, along with body image, changes vastly during the course of treatment, and it's reflected in some of those survey points that I have up here. So this survey that I found, it polled both those in survivorship and those in active treatment to understand the impact of cancer on self-perception, body image, and mental emotional health. Patients indicated that their illness impacted their perception of body in several ways. 50% said that they felt less attractive. 36 avoided intimacy altogether, it's pretty high. And 31% said that they actually felt less feminine or masculine, corresponding with their identifying gender. And then nearly half of all of those said that it affected the bond with their partner. It's a pretty big deal, right? To be going through something so big and feeling like the lack of intimacy is impacting a relationship that's very important to us. On the left-hand side of this screen here, you're going to see this little infographic that I found. It's called the Sexual Health Divide. I haven't been able to find a better one. I really liked this one. It talks about how there is just such a gap in understanding the importance of sexual health and then comfort levels in addressing it. think all of us might have felt this 1 or 2 times in our lifespan. 64% say that their sex life impacts their overall life satisfaction more than time spent on themselves, which was 56%, or even quality of friendships, 51%. And then 69% said that they never talk to a healthcare professional about problems that make it hard to have or enjoy sex. Now, this might be a little bit higher in the cancer community because sometimes our physicians are good about addressing this, and then sometimes they're not. And we could find numbers that are really similar to this. So now let's talk about addressing the physical and psychological effects. And before we do that, we really need to get into some of those functional structures. I would say on average, um, it's pretty high. It's probably about 80% of the people I talk to have a little bit of a gap in the knowledge of where things sit in their body and how they work, and then how cancer impacts it. So let's just jump in a little deeper into some of that sex ed before we move forward on how to start repairing and cultivating that intimacy again. If my computer cooperates with going next. Okay, here we go. So biological female body, we have the external vulva here. That's right here. This is what shows, but the legs actually run all along underneath this labia. This is the clitoral head right here. Gosh, my pointer is really slow. I apologize. The clitoris fills with blood during sexual arousal, and this structure kind of comes and goes in erection depending on concentration and stimulation to this area. The nerves in the clitoris are not always seen to the naked eye, but they actually travel all along and connect with the CNS in our spine right here. You can see my pointer kind of going all the way up to the spine. And then with enough stimulation to the nerves of the clitoris, this message travels up to our brain and it triggers that reflex known as orgasm. This reflex tells our pelvic floor to contract and relax, and that's what's felt. Okay. These pelvic floor muscles are known in 3 layers. We have a superficial layer, and this is closest to the surface right here. It actually connects from our pubic bone right here all the way to our tailbone. We have the mid-range. And then the 3rd layer is the deepest, and this actually holds our cervix in right here. Uterus and bladder are all supported by this 3rd layer. There are actually 14 different muscle sets that are part of the pelvic floor, and I'm going to tell you why that's important to know in just a second. But if you are interested in learning more about the internal function of the clitoris, there's a really great YouTube video. It's called Betty Dodson Draws the Internal Clitoris. Very cool to watch, doesn't take very much time, and it talks all about these structures and gives us an inside view of how this all looks and works. All right, in the body of someone who is biologically male or has body parts in this configuration, and I'm sorry, I did hand draw these. I am not an artist, I am a therapist. So they're not perfect, but they work. We are going to see the outer form of the penis that is akin to the vulva in the woman. That is right here in this hot pink. Okay, this clitoral body is right inside, and it is surrounded by a thick tunic. Okay, it's going to fill with blood and stiffen and help hold the blood into the clitoral body. The pelvic floor is also just as important here. There's a superficial layer, just like we saw a second ago. And this is actually also involved in erection. So it's really important because our pelvic floor, if it's not strong and it's weak, we're going to have difficulty in maintaining strong, firm erections. In this body, it contracts at the base of this clitoral body and it holds that blood in. Nerves still go from the clitoral body to the pelvic floor and all the way up to the CNS in the spine. We also have the prostate in this body, which surrounds the urethra and has nerves that are wrapped around it. Any damage or movement to this area are absolutely going to be moving those nerve bundles and damaging them. And then, of course, these nerves are the same ones that go up to the spine and initiate orgasm and ejaculation. So really, really important when we think about prostate removal or any sort of radiation to this area, what could potentially be happening. Let's talk more about that. So common therapy, how these are affecting parts. For instance, let's start with tissue damage here, right? We might cut out a tumor. There could be tissue trauma to the area. We could have direct trauma, removal of a breast, right? Prostate removal is going to directly affect that ability to have or maintain an erection, like we just talked about a second ago. And then we have the collateral damage that results from tissue removal, and that can look like that nerve damage. Decreased sensation is a really big one that I hear. We have chemotherapy, and that oxidizes all cells, okay, not just the cancer. That's why we're seeing other kind of strange side effects, such as hair loss, change of taste, right? It's damaging all of the cells. We could have radiation. Now that gets rid of cancer cells by destruction of DNA proteins, and it burns the sequencing. But of course, when we're burning harmful DNA, we're also causing damage to those small nerves and passageways that carry messages of pleasure from our pelvic floor all the way up to our spine and our brain. Immunotherapy changes cancer's signals of inflammation, tells your body to attack it. And hormonal therapy, of course, changes our hormonal balance in our body. It is very, very difficult to undergo even one of these treatments. And then we start to pile a few of them together, and we're definitely going to be affecting those nerve bundles and other sensitive structures in our body. So a little bit of grace for yourself is really important. Let's talk a little bit more on direct changes that I see most commonly as an oncosexologist in female bodies, okay? This can be especially frustrating with the hormone changes. We have drugs like tamoxifen, which blocks some of the estrogen receptors in premenopausal women. And then we have aromatase inhibitors, and those block any conversion of estrogen whatsoever for those who are postmenopausal. Both cause vaginal dryness, and they can also cause decreased libido as well. This is really important to understand, because when we're talking about that pelvic floor and the ability for those muscles to contract and relax, removal of estrogen actually hinders blood flow to these areas, and it can cause diminished arousal, dryness, loss of flexibility in those pelvic floor muscles. So that expanding and contracting that's happening down there in those 14 muscle groups can sometimes even be fused, stuck, or not happening at all, or small. Vaginal alterations such as vaginal stenosis and atrophy in the vaginal canal can happen from radiation. It's also brought on by some of these AIs, hot flashes, mood changes. Many premenopausal women have been thrown into menopause with these therapies. And so there can be a vast shift in mood that can really be a tough transition. Genitourinary symptoms of menopause, GSM, is the fancy term, but that really encompasses the vast majority of the complaints that I personally see in my practice. Dryness, burning, decreased genital arousal or orgasmic intensity, discomfort with sex, okay? Last thing I want to say is our interpretation of ourselves. The way we're feeling about all those things I just mentioned, right? Or the way we're feeling about our hair loss, around breast changes, scarring, lymphedema, appearance in general. These automatic thoughts that are popping up for us when we show up intimately with our partner are drastically affecting the way we view our sexual selves, and whether we're cognizant of it or not are really showing up in the bedroom. The last thing I want to say, and this goes for all peoples, okay, 25% people who go through cancer experience psychological distress that is diagnosable anxiety or depression. And this number is 4 times greater than that of the general population. That's a really big number, okay? Cancer changes in male organs. Some of them are going to be really similar to what we just discussed in female organs. They might also be experiencing neurovascular damage that results in erectile dysfunction. Endocrine changes, such as decreased testosterone, could be occurring, which translates to lower libido, higher risk of osteoporosis. I'll give you an example of Lupron for those who have had prostate cancer. Some of the side effects from Lupron can include mood-related disturbances, lack of sex drive, or inability to have or maintain an erection. We might also have changes in ejaculation if the prostate is removed. And although that doesn't interfere with the ability to orgasm, there might be slightly different sensations or cognition around that. That is a big one that I see in my therapeutic practice. And I'll have some patients come to me and say, hey, I don't have ejaculate anymore, and I'm not feeling sexy. I'm not feeling like I want to pursue this, right? It's very, very tough to make that transition. And a lot of this starts in our mind. Even infertility can play a really big part on how we view our sexual selves if we're no longer fertile. So you could also see fatigue, decreased stamina in sexual play. All of these things are really relevant. And then we get into some of those psychological effects that I just mentioned a second ago, but let's build on those for a minute. These are just as important. There is, as we mentioned, such a large amount of depression and anxiety that can come along with a cancer diagnosis, understandably. I just want to take a second and normalize that. I'm often seeing this as adjustment disorders, which last about 6 months in duration, and then typically acute depression or acute anxiety subside, either because the body has reached that new level of homeostasis, we're starting to figure out that unknown a little bit, or they're starting to use healthy coping, right? Kind of getting supports. Things like that. But if you are experiencing longer-term depression or anxiety, your doctor could prescribe an SSRI, selective serotonin reuptake inhibitor, a long word, and that can also exacerbate sexual dysfunction. It can cause a longer time period latency from arousal to orgasm. That can be very, very frustrating for the people I've worked with. They also mean that you might need more intense stimulation. And so if you already have changes to that area, either by hormone or nerve damage, this is, it's just kind of the icing on the cake. Grief and loss is a really big portion of this. We may have structures, body parts, pieces of ourselves that are never going to be the same. And so taking time and space to grieve is really important. I was just having this conversation with one of my patients the other day about how society doesn't teach us how to grieve. And it gets even more ambiguous when we think about grieving a past version of ourselves, right? We just think about that for a second, how hard that is. So I just want to normalize that grief and loss is something that is definitely showing up. And if you're struggling with this piece, I'd really encourage you to reach out to a mental health therapist, your clinic social worker, whomever, for support. There's also a large amount of anxiety that comes in survivorship. We might have automatic thoughts around reoccurrence popping up. I don't know about you, but in my own experience, being a cancer survivor, my fears do not make me feel sexy. Okay. Roles are difficult to also manage during treatment. If your partner was your caregiver and then is also your spouse, how do we go back and forth from that, right? If we're now in survivorship and we're having to redefine this relationship, it can be really tough to kind of take the hats off and on. Distrust or betrayal in your body, even PTSD or acute stress, shows up during treatment at times. So cancer is a very, very dissociating thing to have happen. We have all of these treatments happening to us. And in a lot of ways, it can feel like an attack, things that we don't want to have done to us. So we can typically dissociate, kind of put our head down and just try and get through treatment. And then we come out on the other side and we're like, what just happened, right? That's that dissociation. That's that self-preservation. So if we are dissociating, it's going to be really hard to be physically present in our body and be available for intimacy and sexual play. These feelings can even be more difficult if you identify as trans or non-binary, particularly if cancer has affected a body part that's not a part of your preferred identity. Okay. So arousal and pleasure require, what does it take for us to be intimate with another being? Requires us to be able to be present and experience sensation, that dissociation I just mentioned a second ago, right? We can't be present and we can't experience sensations. It's not going to work very easily. We have to feel that we're deserving of pleasure. This can be a really big one. There's a lot of guilt that comes up with cancer. It's a very, very common thing. And so sometimes this idea like, oh, I don't deserve this. Positive body image. We've gone through a double mastectomy, right? we've had anything removed, we have cuts, scars, lymphedema, all of those things can be popping up. Feeling attractive to our partner. This can be a big one, especially if we don't have our own positive body image. And then if we're on the dating scene, this can be really, it can be another level of intimacy that we need supported. Knowledge that the body will respond with pleasure. Now, if we've had changes in that functioning with the clitoral body, with the pelvic floor, any of those things that we're having latency to orgasm, we might not know how our body is going to respond when we get into the bedroom, right? We might get there and say, oh my gosh, this feels completely different. It can be very frustrating. Safety and trust. Okay. So let's talk about supports. Let's get into all the things that we can do to start to support these structures, start to support the way that we interact in our sexual life. The first thing we're going to start with is our mental health. It's a really big one. Of course, I'm a therapist, so I'm gonna gotta put that plug in there. Okay. Mindfulness has been shown to increase resiliency through recentering of the here and now. It kind of does this for ourselves, like take things that are really big and scary, and it goes boom, and allows us to be present, acknowledge painful emotions or thoughts rather than avoiding or attempting to push them away. If you are new to this practice, I would really encourage you folks to look at the 5-minute guided meditation on YouTube. These are really, really helpful when you're first starting out. And then there's also apps like the Calm app, Aura, Headspace. They have really user-friendly guides, and they can go through progressive muscle relaxation, which is another really great place to start, or other breathing exercises until you feel comfortable pursuing this on your own. But I highly encourage all my patients to start a mindfulness practice. Exercise, this is a big one. It flushes cortisol, the stress hormone in our body. It can be an excellent way to make sure that we're taking care of anxiety that builds in our bodies, excuse me. Just getting our heart rate up with a brisk walk can make a world of difference. Exercise, I'll give you guys an example of this. If we have a ton of cortisol and our sympathetic nervous system is activated, we're gonna have a really hard time connecting with another person. Our brain tends to just shut down. We cannot hear information, we cannot receive anything, we also can't express effectively, okay? It's going to be hard to show up authentically in a bedroom if all of that is going on. So in order to activate that parasympathetic nervous system, get out there and exercise. You can also be mindful, but there's a really interesting study. They found that if a deer is attacked in the wild and it gets away, they actually pause for a minute and they shake all of the cortisol and flush it from their body. So think of it as I need to flush this cortisol so that I can start to think clearly and reactivate my parasympathetic nervous system. A low inflammation diet can help with both sexual health as well as help sustain your energy levels if you're in survivorship or even going through treatment of any kind. This one's really important, making sure you get your fruits and vegetables. And then the last one, I know this one seems so silly, but it is very important to engage in things that increase joy. Sometimes we don't have to make drastic changes to improve our mental state. When I sit down with my clients and explore values, I'm always asking about this joy factor, right? What areas can we increase joy in? How can we start to engage in this idea of savoring little moments of our day where we are able to just say, wow, this sandwich tastes so good. That's small mindfulness, bringing attention to things that bring joy and light us up. Are you a social person? Can you increase the social supports that you have around you? Are you artistic, but maybe through the throes of treatment, you've forgotten and you've stopped engaging in the things that light up that artistic side of you, right? How can we reconnect? Very, very important. All right. Let's start to talk about some of the sexual support. We are going to get into some details here in just a second. This is going to be a general overview, and then we're going to kind of go in closer. So supporting effects of cancer treatment, first line approach for treatment in patients with estrogen or progesterone positive cancers should be non-hormonal therapies, of course. We've got vaginal moisturizers, personal lubricants, and vaginal dilators. Anyone going through pelvic radiation should be started on dilator therapy right away to preserve function. Okay, we can find a constriction in the vaginal canal without those. Second line approaches should include vaginal estrogen therapy, followed by non-estrogen therapies such as progesterone. Okay. Top treatments for anorgasmia is partly practice, getting to know this new version of your body. If you're having a hard time reaching orgasm, we might have to relearn how it's going to show up for you. There's toys. These can be really, really, really helpful because there are situations where that clitoral structure might be desensitized due to nerve trauma. You are not broken. Okay, you have gone through something big and hard in your body. Your body is recovering from trauma, and it is okay to need these. Vibrators can have a frequency that's unlike anything a human body can replicate, and this can give a lot of women a chance to reach stimulation without having to spend hours and hours and getting really frustrated. Spending time exploring this by yourself prior to bringing in partnered play can also reduce that frustration for both parties. Okay. Erectile dysfunctions. We have penis pumps. We're going to talk about these more in a second, but I do always recommend water-assisted ones. These can be gentler and more effective than just the air ones. These are really important. Automatic ones are the least effective, just FYI. Erections rings can be an excellent tool to be used in tandem with penis pumps. That helps trap the blood in the penis. And it's going to be very, very helpful in maintaining that erection for play. You don't want to leave erection rings on for more than 20 minutes. File that one away. Medication, you can also bring this up to your doctor or urologist. If medications are not an option, there's also more invasive injection methods, but you're going to want to have a conversation with your doctor for this one too. But even if you're not able to have medications, pumps and erection rings are very, very helpful. We'll talk about that more in a second. I'm getting ahead of myself. If you're going through penile rehabilitation, which we're going to talk about, I really encourage you to bring your partner along, right? This goes for both genders, anyone here, bring your partner along. I know that doesn't sound sexy. I know that sounds hard. There is a study called Eroticization as a Factor Influencing Erectile Dysfunction Treatment Effectiveness. Found that bringing your partner along in the journey helps to eroticize the aids that we need for both parties, and it increases fosters a sense of intimacy. Okay, it can be really hard. I hear my patients say this all the time. Francesca, I don't even want to tell my partner about what I'm going through. I want to fix it first and then tell them, right? Or fix it and come to a level that I'm okay with and then come back to them. And that's fine. But we don't know what this new level holds. We don't know what the future holds. And sometimes bringing them along with you, it really gives us a chance to, right from the beginning, get that support, but also have fun and play. And a lot of sex is about play more than just an orgasm, right? How do we intimately connect and have fun with something? Of course, we have pelvic floor therapy, which we'll talk about more. Okay, let's get into penile rehabilitation. This is going to be a lot of information. There is a handout here. I have both penile rehabilitation and vaginal rehabilitation that I think Rachel's going to plug into the chat here. So please take a look at this. It goes through so much detail. I'm going to touch and give you the overview of it now. Recovery post-prostate, colon, or rectal cancers. All of this can take about 3 years to heal that damage from the pelvic floor. So rehab activities are important for all 3 years, but they're especially important in the first 6 months. If you are experiencing soft or no morning erections whatsoever, this is definitely for you. Neuropraxia is this fancy word for nerve damage. It cannot heal itself, and it requires active participation, just like if you were to, go to a physical therapist after a knee replacement, right? We are trying to prevent scarring inside of that clitoral body. We are trying to increase blood flow. We just need some more support. So we are going to increase oxygen exchange to the penis. We're going to maintain length and girth to support full erections after nerves have recovered. And that is what the four main components of penile rehabilitation do. The first part of this is starting on a nightly dose of PDE5I medications. Now, you're going to want to check with your doctor, but chances are you might have already been prescribed this if it's available to you. This means a small nightly dose of tadalafil, Viagra. It increase as you're able to up to that maximum physician recommended dose. This is simply helping with those morning erections, increasing that blood flow and allowing that penis to regain the original strength of blood flow so that healing can occur. Technique 2, that's part of this four main components, is stretching and penis massage. This is about increasing blood flow again, not about obtaining an erection. There's a technique to this. I'm not going to go over it here for time's sake, but it is outlined in detail in that handout that I just mentioned a second ago. Vacuum erection devices, or VEDs. These are so important. I just mentioned them a second ago when I talked about liking the water-based ones. They draw blood via vacuum into the penis and allow it to flow out again. VED therapy has a really high rate of consumer satisfaction. It's actually 92%. And most importantly, it is the only therapy that preserves both length and girth of clitoral caverns inside of the penis. Remember way back when we talked about all of those structures, we want to preserve that length and girth so we can maintain full erections afterwards. The vacuum stretches the tunica while pumping blood in and out of the penis. There's also a technique that's outlined in detail during in that handout for using the VEDs. I recommend doing this at minimum 2 times per day, especially in those first 6 months. I know that sounds like a lot. You can do it once in the morning and once in the evening. The last thing we can do is strengthen our pelvic floor. I told you I was going to put a plug in for this, right? There are some exercises that are outlined in that penile rehabilitation handout on contracting that and figuring out how to really hone in on those muscles. But strengthening those is so important because, as you remember, it traps blood into the penis during erections. And so this also helps with maintaining firmer ones when you're engaged in play. So lots of information there. Please go over that handout. Very helpful. It's a handout that's created by Ellen Barnard. She's a sexuality educator. I absolutely adore her. She's created wonderful handouts. I don't want to remake something that's already great. So I'm going to pass along hers. They're all free on her website. You are also welcome to check out her website. I think it's called A Woman's Sexuality Center. I'll make sure before we end today that I give you the correct website. Okay. Vaginal rehabilitation. This also includes increasing blood flow. I don't know if y'all are seeing a pattern here, but blood flow is so important. Okay. We want to massage this through the external vulvar structures and the internal vaginal structures. There is no hormones here. That's the best part of this. A lot of us can't have those hormones. So this is a really great place to start. One thing I want to say, stop having painful sex. If penetrative sex is hurting, this will build a behavioral feedback loop in your body that will make anticipation negative. I have patients that come to me and say, you know, my husband will approach me and it'll be late at night and maybe he'll give me a hug or he'll start kissing me, and all of a sudden, boom, I am like, get away from me, go away, I can't do this. And I ask them, have you been having painful sex? And they say yes, right? Our bodies will find ways to shut down our libido, to increase pain, to do whatever it takes to keep us from getting hurt again. So what we need to do is we need to figure out where the pain is coming from, address it, and then resume, okay? If penetration of less than 2 inches is comfortable in the vagina and you feel as if you've run into kind of a wall there, you can be experiencing something called vaginismus. That's something I also treat as a sex therapist, and it's the involuntary contracting of the pelvic floor and the vagina in order to prevent penetration, right? That protective measure that our body's taking to keep us from feeling pain. Or it could also be that you've lost the ability to relax your pelvic floor. This is called high tone pelvic floor dysfunction. It may be helpful to go to a pelvic floor PT and tease this out. They can actually help you learn how to relax those muscles if that's the case. So as far as rehabilitation exercises is concerned, if you're having pain during penetration, it is especially important to massage the perineum. That is that area between the vaginal opening and the anus. The handout that I have here, it's going to go into in-depth detail on how to massage. This is not masturbation. The objective is not an orgasm, but again, blood flow, healing those nerves and those small capillaries that we discussed earlier. We're trying to increase all of the blood flow to that area. And we're using moisture, right? Massaging the internal vaginal canal, if that's accessible to you. We're wanting to bring healing to that sensitive area. And we use, on the handout, it's going to talk about this more, but we're using internal moisturizers and external lubricants. And this also helps heal that tissue that can be weakened by lack of natural moisture if you're on any of those aromatase inhibitors. Okay, or if you're having removal of all those hormones and you're having damage to the tissue as a result of that. Okay. All right, this is my fun plug for Other Course. Okay, Other Course is simply creative play that doesn't focus on intercourse. This is a really great way to discover alternatives to your sexual routine. It's basically anything that's not PIV, penis and vagina sex. Okay, fun word, love to say it. You can really build anticipation when you agree that neither one of you are going to aim for orgasm. You can keep your clothes on and explore heavy petting, right? Kissing, snuggling, having sexual and sensual play without penile erections. Other Course is a really great way to explore this. And since men can still have orgasms without an erection, you can try different parts of your body to provide stimulation and explore that. This is good for anybody who has performance anxiety, having trouble reaching orgasm, pain with penetration, or maybe you just don't enjoy penetration, or you want to just postpone intercourse, but still enjoy play. One thing that is so important, and one of the reasons why I put this slide on here, is I hear my patients say to me, oh, you know, during cancer, I have completely stopped everything. We are not intimate whatsoever. We don't touch, we don't hug, we don't kiss. And this creates what I've seen clinically, right, is it creates this little bit of a divide where it makes this hump even harder to get back into it when the time comes. And so increasing the amount of intimate time, even outside of sex, even outside of penetration, is very important. Spend time hugging, spend time snuggling, spend time just even watching a movie together and touching in some way so that we can know that when we are ready for sex or when we are ready for intimacy, it's going to be more available to our body, and that huge wall feeling won't be as profound. All right, lubricants. These are some of the main ones. There's a difference between moisturizing and sealing. Moisturizing can be used daily to help keep the skin and the vagina moist, especially if you're on any of those AI therapies, anything like that. We could be struggling with vaginal dryness. So these can be inserted by night with a syringe or an applicator to moisturize the skin. I typically recommend my patients do this at least 3 times a week. It's very, very helpful. Sealing, these stay on the surface. It keeps it slippery so that it doesn't tear during activities. We want to apply this to both partners. This one can be hard. I hear a lot of cognition around lubricants as a sex therapist, right? Like just this idea of maybe I'm broken, or why can't my body do this anymore? This is one where I find grief comes up a lot. So I just want to normalize that. Some of us, we've needed this from the very beginning, and so we might not experience that same thing. So we're all over the place here, but both are okay. And take some time to sit with yourself and figure out where your cognition lies when it comes to lubricant, if that's no longer readily accessible to your body in the way it was before. All right, one of the most common things I hear at post-cancer treatment, the feeling, we're referring to desire here, just isn't there, but I still want to increase intimacy. What do I do? One of the biggest shifts that I see in a post-cancer body is actually from something called spontaneous desire. That's that feeling of, oh, I'm turned on, I just randomly want to have sex, to responsive desire. Now, there is a huge gap in all of our desire styles. That is okay, and that is normal. Some of us might have been spontaneous before, some of us might have always been responsive. Both are normal. But what I find frequently in cancer is that we will move over to that responsive desire. And that means that we might not feel that feeling until after we are in the middle of sex or in the middle of intimacy. So if you're wanting to increase intimacy or sexual play, you can simply begin and see where it takes you. Often that feeling can build halfway through. It might not be there at all, but you can still have an incredible sex life and feel fulfilled in your sexual being without that physical body response desire. Your emotional and psychological desire is just as important. So libido is the cognitive awareness of desire in the body. It's reinforced by physical sensations and positive or negative outcomes of sex play. That's a little plug for painful sex, right? If we're having painful sex, it's going to say no thank you. Desire may be present even though physical arousal happens slowly or sensation is diminished, but the awareness can also change as the experience changes, as you get deeper into play, as you get deeper into intimacy and feeling supported. Let's talk about this a little bit more. Conscious intent. Let's think of this as kind of like the vehicle for responsive desire, right? This means that desire can start in our brain. Conscious intent means that we might not be going along with a feeling, physical feeling. We might be going along with a mental thought or a desire that we have cognitively thought up. So a good thing to ask yourself is, what do you want from intimacy? Do you want a feeling of safety, feeling of being supported? Do you want to feel confident? Do you want to feel in control? Right? There's a lot of really fun things that can be explored as far as when we start to ask ourselves, what do I really want from this encounter? We want to develop a new interplay with desire and action. So that means learning different ways to initiate intimate play that don't rely on our body leading the way, giving the mind permission to be in charge. Our bodies are really non-concordant. There's a lot of studies out there. You can Google arousal non-concordance. You're going to find so much stuff. But this basically means that we might be super aroused cognitively and our body might not have natural lubrication, or we might be very aroused and we might not have an erection. Okay, these are very, very normal, and vice versa. We can experience an erection and not be turned on at all. So again, bodies are non-concordant, and we don't want to rely on the body leading the way, particularly post-cancer if we're trying to increase intimacy, because there's also a little bit of that dissociation that's happened and all of those other symptoms. So giving the mind permission to be in charge is really, really important. It might not feel the way it used to, but offering a little bit of a reframe here, I'm going to keep having fun and discovering what it can offer me might be a nicer way to talk to yourself about that. And then last, that's that idea of responsive desire, right? I'm in the middle of it. I have chosen to participate. This is feeling good and fun, might not feel the way it used to, and I'm enjoying this time with my partner. I'm going to plug in grief again. Hey, this is a really, really big one. It consistently pops up post-cancer, and I found it to be pretty relevant, even if you've had a really stage 1 breast cancer all the way to metastatic disease. I'd say that grief is one that consistently pops up for each and every one of us. And so writing details, this is a little exercise that I think is really, really helpful to some. I encourage you to write a goodbye letter. Starting that grieving process, figuring out what grief could look like for you moving forward. What has been lost or changed since cancer treatment? You can do this individually with a partner, and it can help you reconcile what is no longer and what does the future hold. Grief is going to continue to pop up for a long time, and some of us even carry grief throughout our lifespan. But it doesn't mean that it's always acute. Sometimes it looks more like little pokes, right? Little moments where like, oof, I miss this, right? So starting this letter and just writing down all of the ugly, all of the things that are feeling hard, that are feeling difficult, all of that grief that is built up in our system, getting it all down on a piece of paper, it can really help reconcile. And then the next thing that I like to say is it allows us an opportunity to invite the new, okay? Cultivating the new aspects of yourself. As you begin to learn about your new body, about the new ways that you feel intimacy in your body, the new ways you feel arousal, they're probably not going to feel exactly the same. What can we look forward to? What are we excited about discovering? Exploring and inviting exploration is really, really important because it just opens that door, right? Just that little head shift into what can I figure out about myself next? What does the future hold for me? So that can be another letter that we do at a separate time. And you can even do this with your partner too, and you guys can draw up what you're excited to explore together. Maybe this would be a really good Valentine's thing to do tomorrow. Okay, that is the majority of thing. I think we still have some time for questions. Let me see here. Okay, A Woman's Touch Online, www.awomanstouchonline.com. That is the website for Ellen Barnard. She has tons and tons of great resources. Check that out. I think Rachel put the other stuff into the chat. And I am going to stop my share. Is that okay, Rachel?
Yeah, that's fine. I'll go ahead and add everything that you kind of touched on today, all those links and stuff. I'll add them on the email that we send you guys after this presentation. You'll probably get that email on Thursday. It'll also have all the handouts that are in the chat as well. And I know that there's probably some questions, but I always like to start asking the first question so that anyone who maybe is feeling a little nervous about this topic or asking specific questions about themselves feel comfortable to step forward. So I'll go ahead and start with one that I had towards the beginning is how do you start conversations with your partner or caregiver about your feeling towards intimacy? Because you mentioned like bringing them along to the therapy, penile or vag therapy session, rehab sessions. And I was just trying to see how do you start that conversation?
Yeah, that's a great question, Rachel. So I think one thing I would encourage is simply sitting down with your partner and maybe starting off with, hey, I really miss this. How can we get it back, right? And name a feeling. Feeling words are really great when we're connecting with our intimate partners because they're not inflammatory. They don't cause a triggered response as much as direct things like, why aren't you doing this anymore? Or, I can't do this anymore. Rather, we start with, hey, I miss deep connection with you. I miss the feeling of your fingers on my body, right? What can we do to re-navigate that, even in the middle of treatment? Right? It doesn't have to just be sex play. It can also just look like supportive feelings and hugs.
Mhm.
So starting that conversation early is also really important, and I would highly encourage that too.
Okay, so you're sitting down with your partner and you're asking them or you're telling them how you're feeling and what you want to do to get back to that feeling.
Yes,
Okay,
exactly.
cool. Another question that came to mind is how do you relearn how your body will respond in the bedroom after or during cancer? And is there a way to do this with minimum frustration?
Yeah, another great question. This one is tough because it's going to be different for every single person. There are some people that I work with that are fairly sexually open, and masturbation is really available to them. Then there's some people that I work with that have never engaged in self-play, or that maybe have strong cognition around self-play. And so this is going to look different for both of those people. But really, in order to figure out how your body is going to respond, it does require a certain level of being able to figure out what's going on and engage in self-play. So one thing I would say, if you are in the latter category, not wanting to engage in self-play, or something that has not been common for you throughout your lifespan, doing a body map or a body inventory. Take yourself on a date, go in a bubble bath, start from your toes all the way up to the top of your head, and figure out which parts of your body do you love? Which parts of your body do you have great sensation? Which parts of your body are causing grief? Which parts are not online like they used to be? Taking that full radical inventory without judgment, without judging yourself, and starting to understand. Another thing I would say is, it's so important to understand what damage, if there is damage that has been done to our intimate structures. And so especially men, y'all hold your penis every day when you go to the bathroom. Women, a lot of us don't even know where we pee from, okay? So urethras are not physically visible from the outside unless we pull everything back. So women, get a mirror, go down there, figure out where everything is, make sure you're pulling back the hood of your clitoris and making sure things aren't fused, making sure that there's good blood flow to that area. You're going to want to make sure that all your structures are online. There's a lot of things, and I mentioned that can take those structures offline. So doing a deep dive with a mirror can be really, really helpful too.
Good. I like how you give real life examples of like exactly step by step, this is how to do it. Take yourself on a date, get in the bubble bath, get the mirror out. These are what you need to do. Okay, so another question that we have is, how do you know if you're responsive versus spontaneous desire? I know that you kind of discussed it as like it can change when you have a cancer diagnosis or after your cancer diagnosis, but how do you determine which one you are? Like, is there a quiz online, or do you just have to self-identify? What does that look like?
Yeah, actually, you know what? There is a quiz online. If you go to, ooh, hang on, it's going to come right back to me.
Mhm.
Oh my gosh. Oh, Emily Nagoski worksheets. Type in Emily Nagoski worksheets in Google. It's going to pull up her worksheets from her book, Come As You Are. It's a wonderful book for women. Highly encourage you to read it. But her worksheets, she does have a quiz for spontaneous versus responsive desire styles. But a good way to also just tell for yourself, if you are somebody who typically throughout the course of the day can spontaneously think of sex or spontaneously feel desire, you're probably in a spontaneous category. If you're somebody that historically throughout your life needed somebody to come approach you and maybe give you a massage or hug you, and then your body lit up, then you're probably more responsive. Now, those typically change. So just paying attention to, what is your body needing now, right? If you're not thinking about sex at all and your partner approaches you, what happens? Getting introspective. But yes, go check out the quiz.
Okay, I'll have to add that one in too. Okay, so we do have one question from the attendees. What if you don't have a partner? An idea of intimacy and sex feels terrifying with a new person. Do you have any advice?
Absolutely. Absolutely. I've had several patients, because, I am a sex therapist and I see people individually. I've had several patients come to me and say, I am back dating post-cancer. The first and foremost thing I would say, learn what you love and what you like about yourself, and be willing and able to show up with your desires on the table when you are navigating dating. So what I mean by that is knowing that you might need a vibrator and showing up with it and saying, this is what I need to orgasm. This is what I like. This is what I want to see. Right? And just being very, very authentic to what your body needs. There is nothing wrong with that. And I've had some people tell me that they've had wonderful success in getting what they want from their intimate experiences out in the dating world. But the first thing that we have to do is really take a look at ourselves, make sure that we're not dissociating in any way post that treatment. And that body image, that plays a really, really big role in how we show up in the dating world. So making sure that we are supporting our own body image is really important too. If you need help with that, just generally speaking, supporting body image post-cancer, I'd encourage you to go seek out a therapist and talk through some of that stuff.
Yeah.
It can be hard to negotiate on our own.
Okay, we'll take one more question and then we have to close out. So the last question is, can blood flow be restored after a period of time without need to continuing massaging and moisturizing regularly?
Yes,
Okay.
absolutely. But I'm going to put in a little caveat here. If you are on an AI therapy, aromatase inhibitor, anything like that, tamoxifen, your blood flow is going to be diminished down there. So typically those hormone therapies are 5 years post-cancer. You're going to want to put some sort of moisturizing inside of the vagina for those 5 years, unless your body starts to resume functioning on its own after the 3. Sometimes we can find that, but for men, that can resume as well. We want to be checking on if we're having firm erections in the morning. That's going to be a really good indication for us. Especially those first 3 years are probably going to be really important. And again, any of those hormone therapies are getting rid of moisture, so we want to make sure that we're keeping the moisture in there. I hope that answered the question.
Okay, so that was our last question of the day. Thank you so much, Francesca. We appreciate all your time. And we're just going to kind of close out with some closing remarks. So just a reminder, this session was recorded and will be sent to all registrants in the follow-up emails. So maybe this is something that you go over with your partner on Valentine's Day, just have like a little education session. And it will also be available on our Texas Oncology Foundation website. We will not have another upcoming webinar this month, because we are going to be promoting a nutrition workshop, which is February 22nd at 6 p.m. with one of our dietitians, Karen Smith. I'll go ahead and add that link to join in the chat now. If you guys are interested in signing up for that event, it will also be on the follow-up email as well. If you're interested in more topics like this, make sure you like our Facebook page, follow us on Instagram, and stay current with our foundation, because we have programs like this throughout the entire year. And we can also dive in a little bit deeper with topics like intimacy with Francesca in a virtual experiences or other programs. We have mentors and meetups every Friday this month. So if you're interested in meeting others with cancer, this is a great one to go in person or virtual in the Austin area. And then finally, we value feedback from our community. So once we exit out of this program, out of the Zoom session, you'll be seeing a link pop up on your screen. It's a SurveyMonkey link. We do ask that you take some time to let us know how this was for you. If you had any follow-up questions you'd like to ask Francesca, you can also ask them there as well. So thank you so much, Francesca, for coming with us today. And hopefully we'll see some of you guys on February 22nd at 6 p.m. for that nutrition workshop.
Thanks, everyone. Bye.